In this very special episode of our podcast, we discuss the results of the ALPINE trial with Dr. Laurie Sehn following the dissemination of the results during the late-breaking abstract session at the American Society of Hematology meeting in New Orleans. Dr. Sehn is a clinical assistant professor in the Department of Medicine at the University of British Columbia and medical oncologist at BC Cancer in Vancouver. In this episode, Dr. Sehn discusses the impact of the results of the ALPINE trial for clinical practice in Canada, given the achievement of superior progression-free survival of zanubrutinib over ibrutinib for the treatment of relapsed or refractory chronic lymphocytic leukemia and small lymphocytic lymphoma. Hope you enjoy it. So welcome, Dr. Sehn, and thanks so much for joining us following the exciting results of the ALPINE trial that were presented during the late-breaking abstract session at ASH in New Orleans. So I wanted first to ask you about the rationale for the development of second-generation BTK inhibitors following the success of the first-generation molecules such as ibrutinib.
Well, we know that B-cell receptor signaling is really essential for CLL expansion, and that BTK is an important component of the B-cell receptor pathway. So ibrutinib, which was a first-in-class BTK inhibitor, was really a major advance in the treatment of CLL because it was a form of targeted therapy that led to very relevant efficacy and really allowed us to move away from chemoimmunotherapy as a major treatment for CLL. However, there is room for improvement. We know that with ibrutinib, there are some off-target effects that result in toxicities and tolerability issues, particularly the risk of cardiac events. So the goal of second-generation inhibitors really has been to try and improve the specificity for BTK with the hope of, lowering these off-target effects and hopefully lowering toxicity, but also possibly improving efficacy.
That's great. And what are some of the specific safety concerns with the use of ibrutinib? And how do you feel these might be improved on with the use of newer generation molecules?
It's been a learning curve for clinicians for sure in terms of the management of patients on BTK inhibitors. They come with a unique set of toxicities that I'm sure most clinicians that use these drugs are now well aware of. The primary safety concern, to be honest, has been the risk for cardiac events. So we see concerning risk of atrial fibrillation, for example, with ibrutinib that needed to be monitored for. Other risks include hypertension, risks of bleeding complications, myalgias. And, of course, the hope would be that the higher specificity you have for BTK as a target, the lower some of these toxicities might be due to lower off-target effects.
And so with the advent of the ALPINE trial and these new results, what is the rationale for that trial? And, can you give your thoughts on the selection of the choice of overall response rate as the primary endpoint?
So ALPINE was a large phase 3 trial. So it's a 1-to-1 randomization in patients with relapsed refractory CLL who had received at least one prior line of therapy. And they were randomized head-to-head to either the standard dose of ibrutinib, which is 420 milligrams daily, versus the standard dose of zanubrutinib administered here at the twice-daily dose of 160 milligrams. In this trial, the primary endpoint was overall response rate, which I suspect was designed because, we can get that information more quickly. And while response rate is an important parameter, as a comparator for efficacy, I'd say that the more clinically relevant endpoint is progression-free survival. And importantly, in this trial, progression-free survival was a pre-planned secondary analysis. And this is what we saw reported in this update of the ALPINE trial.
Right. So do you feel that given it was a secondary endpoint, do you feel comfortable with the results being able to show superiority?
I think that, the statistical evaluation within this trial was quite thoughtful and well planned. So although progression-free survival was a secondary endpoint, it was a pre-planned analysis, and they used an interesting hierarchical statistical plan. So I think, from what we would have anticipated, I don't know that we were fully expecting to see an efficacy benefit here. So it was initially planned as an assessment for non-inferiority, but there was a built-in plan that if it met its endpoint of non-inferiority for efficacy, that it could then be tested for superiority with a more stringent p-value applied. So I would say that, that this should be a very valid design to let us assess efficacy.
That's great. That's very comforting. So, and then if you think about the efficacy results of the study, can you describe your thoughts on the results for both overall response rate and progression-free survival?
So the primary endpoint was overall response rate, and that was significantly higher with the zanubrutinib compared with ibrutinib. So it was 86.2% versus 75.7% with a pretty impressive p-value of 0.0007. More importantly, though, from, I would say, the clinical perspective, is that progression-free survival was actually shown to also be improved with the zanubrutinib compared to ibrutinib. So this was assessed by an independent review committee, and the hazard ratio was 0.65. I think, also intriguingly, that when they looked at the higher risk subgroup of patients with deletion 17p or TP53 mutations, that difference in progression-free survival is actually even greater in that group, with a hazard ratio lower at 0.52. And looking across different sort of the other more important subgroups, or I would say most important clinical subgroups that we recognize, including IGHV status, all of the results favored an improvement for zanubrutinib over ibrutinib.
That's wonderful. And can you talk about the absolute difference in progression-free survival, and what threshold do you see as being, for yourself, clinically meaningful?
Well, if we look at the 2-year landmark, the difference in progression-free survival was just probably a little bit over 10%. So it was 79.5% for zanubrutinib versus 67.3% for ibrutinib. So, I think I would say that, that absolute difference is clinically relevant. So, in fact, it's about a 12% difference between the groups. I think also, quite noteworthy, if you look at the absolute difference in 2-year progression-free survival for the very high-risk group of patients, those with 17p deletion or TP53 mutations, the absolute difference is even greater at, 77% versus just about 55%. So that's over a 20% difference in that subgroup of patients.
And so what would you think of as the threshold where you would say, okay, above this percent of difference in progression-free survival, that should be clinically meaningful?
I think that I'd probably put that threshold at about 10%. And here we're seeing more than 10% in the intention to treat cohort. And then, as I said, more than 20% in that high risk cohort.
That's wonderful. So what are your thoughts on the difference in the discontinuation rates between the arms? And could this have explained this difference seen in efficacy completely, or could there be other factors involved?
So there was a lower rate of discontinuation due to adverse events seen with the zanubrutinib versus the ibrutinib. And this included a lower rate of discontinuation due to cardiac events as well. Also, importantly, there was a lower rate of dose interruption as well as dose reductions seen with zanubrutinib. So, what this tells us is that the zanubrutinib was more deliverable. So this likely factored into the difference in the efficacy we see, but it probably doesn't tell the full story, because we also see that there was a higher rate of discontinuation due to progressive disease in the ibrutinib arm. So 42 patients actually discontinued due to progressive disease versus 24 in the zanubrutinib arm.
Great. And so just talking about the differences seen in the adverse events between groups, what would you say were the most notable differences from the results?
So importantly, the rate of grade 3 or higher adverse events was lower with zanubrutinib, as well as the rate of serious adverse events, which was 42% versus 50%. Probably the main difference really was the lower rate of cardiac adverse events that was seen with zanubrutinib. So overall, it was 21% versus 29, just over 29% in the ibrutinib arm. But importantly, the rate of serious cardiac events was notably lower with zanubrutinib at 1.9% versus 7.7%. Also, if we look at fatal cardiac events, there were 6 fatal cardiac events in the ibrutinib arm, but none seen in the zanubrutinib arm.
That's great. And what would you, if you can comment on what these results mean for clinical practice in Canada?
Well, clearly, the safety profile is definitely in favor of the zanubrutinib. In particular, the lower cardiac risk, I think, is highly relevant. So this would lower the burden in the Canadian environment on the healthcare system. In my own practice, when I have a patient who develops a cardiac event, I usually refer them to the cardiac oncology clinic for management. This is getting a little more difficult because they are, at capacity most of the time these days. And of course, this type of specialty care is not available in many places and to all oncologists treating patients with CLL. So I think that's a relevant decrease in burden in terms of management for complications.
That's great. And so based on the efficacy and safety data from the ALPINE trial, would you then choose to give zanubrutinib over ibrutinib in all patients where you would give a BTK inhibitor?
So the ALPINE trial, I think it is a very important trial in that it was a large phase 3 study, well powered. And what we learned from this trial is that, compared to ibrutinib, zanubrutinib definitely had the better toxicity profile. And I would say, also maybe a little surprisingly, but, a clear demonstration in this trial that it appears to even be more effective. So, in my own clinic, I would say that zanubrutinib, clearly based on the results of this trial, would become the preferred BTK inhibitor that I would choose.
That's great. And does that translate also into the comparison between zanubrutinib and acalabrutinib, even though they weren't directly compared? But if you had a choice of BTK inhibitor, would you go for zanubrutinib in this case?
Yeah, that's a good question. We don't have a head-to-head comparison of zanubrutinib and acalabrutinib, although we do know that there was a prior trial that compared acalabrutinib to ibrutinib in patients with slightly higher risk CLL with deletion 17p or deletion 11q. And in that trial, while acalabrutinib showed a better tolerability profile to ibrutinib, it didn't show an improvement in efficacy. So, I don't want to get into too much in the way of cross-trial comparisons, but really ALPINE is the first study that truly has demonstrated the superior efficacy of one BTK inhibitor over another. So I would say that, I think it does make it a preferable choice.
Yes. Okay, great. And in terms of the line of therapy, I realized that ALPINE was performed in a relapsed refractory population, but would you, if you were choosing first line therapy as monotherapy, would you then also apply this there?
So that's a really good question. We don't have a head-to-head comparison in the frontline setting, and I suspect we will never see a frontline comparison at this point. But I would say that given the results of the ALPINE trial, which was a well-powered phase 3 study in relapsed refractory patients, I think that personally I'd be willing to extrapolate this to frontline in terms of selecting BTK inhibitors for patients who require it for untreated CLL.
Okay, well, thank you so much, Dr. Sehn. I really appreciate you joining us, and I hope you had a really good ASH meeting. And thanks so much for sharing your thoughts on this exciting data from ALPINE.
It was my pleasure.